Oh, I have to hit continue because you're recording the meeting. There we go. Okay. Hey, y'all. Apologies in advance if there's a lot of background noise. I am doing this from home and there is some construction nearby. So hopefully you can all hear me. But if not, give a wave or a shout and I'll try and fix something, although I'm not totally sure what I'd fix. So my spiel today is on hypertension. And just start off with kind of why we're here and what I'm trying to accomplish. There we go. So, obviously my primary objective is I want to equip all of you to manage hypertension in the clinic. That's pretty low hanging fruit. I expect that most of you probably already know how to do that. So I've tacked on a couple of other things. I want you to feel prepared for step 3 because secondary hypertension, when it comes up in a clinical setting, is actually pretty easy to deal with. You look up what to do, but if it comes up on a board exam, then you need to know a few things. So we're going to actually spend, I don't know, 2/3 of our time talking about hypertension in general, and then we'll spend maybe the last third of the time just kind of going through some very specific bang, bang, bang scenarios on secondary hypertension so that you guys have a little bit of boards prep in there as well. This is, of course, assuming that step 3 is going to happen someday. I aim to be devastatingly amusing. I usually fail, but I'll try. And because Renata is actually coming after me with the dizziness talk, and it is essential that I finish on time. So I'm going to blow through this and try and monitor our time as we go. In terms of how to manage the Zoom stuff, I'm going to be asking you guys some questions. Please put answers in the chat and I'll just kind of track those, and vice versa. If you have questions for me, I'll also keep an eye on the chat for that stuff. And I'll just kind of pause periodically to answer questions if needed. So are we all good? Thumbs up from someone, please. Someone. Okay, good. Whew, you're out there. The thing with everybody being muted is just really hard. It's like, I can't tell you how dead this room feels right now. Let's jump in with Mr. J. 52-year-old guy comes in for evaluation of elevated blood pressure. He's coming in because he stuck his arm in one of those things at the grocery store. You know the thing I'm talking about. It kind of usually sits outside the pharmacy or something, and found it was 148/88. Okay, timeout. What do y'all think of the grocery store blood pressure machine? Good, bad? I see a shrug. Alex says fine. All right, we got parallels. We've got the ends of the spectrum here. We've got fine, we've got bad, we've got I don't know, we got they're probably not doing it right. So the technology behind those machines, and then the question is it as good as home BB? That's a great question. In terms of whether or not it's doing it right, the technology behind those machines is the same oscillometric stuff that we have in ICUs and automated blood pressure cuffs that people have at home. So the technology is fine. The major limitation is it's a one-size-fits-all cuff. And so people who have really big and really skinny arms may not have a great reading. I don't know how many of you have done one of these things before, but you'll notice that what it actually does first is it adjusts itself to your arm. So it'll like blow up really fast and really gently. And then when it figures out it's got a grip on your arm, then it starts crushing your arm to measure your blood pressure. So in general, they're actually pretty good. They're definitely a lot better than nothing. How they actually compare to true home blood pressures, as far as I know, there's no data on that. They're probably better than what you get in the office from the point of view of white coat hypertension, but compared to like a home ambulatory monitor, I don't know. Bottom line is, someone comes in with 148/88 in the grocery store, you should probably treat that as a valid reading. When you continue to follow them, it wouldn't hurt to find other ways to measure their blood pressure, although this is still legit if it's really the best thing they've got because it's free. Other free resources, at least here in King County, firefighters will do it for free. That's an easy thing to do. And then if you are lucky enough to have a clinic at the VA will provide patients with a blood pressure cuff for free. Most other places, you can prescribe it. It may or may not be covered by insurance. They typically run, you can spend anywhere from like 30 to 40 for a low NBP cuff that'll work just fine, up to 100 plus if you want something that measures multiple people and connects via Bluetooth. The underlying quality of the numbers is probably all the same. So he's 138/86 and his heart rate's 84. So he's here in clinic. We've got 2 readings now. BMI is 28. He doesn't exercise regularly. So the first question, how many of you think this guy has hypertension by some legitimate definition? Okay, got a yes? Wouldn't consider this two separate visits. Okay. Repeat BP at follow-up. I think in terms of it being two separate visits, as long as he didn't like come in, as long as he didn't do the grocery store that morning, it probably is two separate legitimate occasions. So I think he meets the two measurements criterion, although the two measurements criterion is a little bit old, and we'll come back to that. So most people are saying that he has hypertension. And Erica is qualifying that with using the new stricter requirements. Okay, so thank you for that segue, Erica. So whether or not this guy has hypertension kind of depends on how you define hypertension. So referring to the new stricter requirements that Erica is talking about, I think she's talking about the ACC AHA 2017 guidelines. And the major difference in there is in those kind of, they bumped what used to be, what's here, let's see, can I show you on this screen? Maybe, yeah. So what is now stage 1 hypertension used to be elevated, and what is elevated used to be within kind of the normal limits. So basically, people who have systolics in the 130s and diastolics in the 80s now have stage 1 hypertension. And that is new because that used to be, the cutoff for stage 1 used to be 140/90. And kind of these two boxes were gamished together into pre-hypertension, which you'll notice is no longer on there. So why did they do this? They had a legitimate reason for doing this from just an epidemiologic point of view, which is if you look at large population databases, it's pretty clear that the risk of cardiovascular mortality doubles for every 20/10 that you are over 115/75. So for example, someone who's 135/85 actually has twice the risk of cardiovascular mortality as someone who's 115/75. You're like, twice the risk, oh man. But you've got to remember the difference between relative and absolute risk. So we are all a little bit too familiar with what exponential curves look like these days. And this is a true exponential relationship. So if your relative risk of having, a cardiovascular death at 115/75 is 1%, it's 2% for 20/10 over that, then 4, then 8, then 16. So as you can see, each 20/10 is not equal. So from an epidemiologic perspective, yes, people whose blood pressure is above the normal range are at elevated risk. The degree to which their risk is elevated compared to the old normal, or compared to, basically what would have been pre-hypertension, the absolute risk increase is pretty darn small. It's going to be bigger it's going to be higher if they're older. So if you actually have a 60 or a 70-year-old, then that absolute risk increase is going to be larger because their baseline risk is larger. But when you're talking about a lot of the population that's involved here, which is kind of the young to middle-aged age group, the absolute risk increase is pretty small. Can anyone think of a downside of expanding the definition of hypertension? Alex says overtreatment. John says more meds. Yeah, exactly. So the bottom line is, for any screening test, doesn't matter what it is, measuring blood pressure to see if people have hypertension, measuring PSA, take your pick, colon cancer screening, breast cancer screening, whatever. The purpose of screening is to take someone who thinks they're healthy and inform them that they're sick. If you're going to do that, it is actually incumbent upon you to do something for them once you've done that. Otherwise, all that you've done is told a healthy person that they're sick, and generally speaking, that doesn't help anyone. So the reason why this is controversial is, if you look at this next slide, there's two sets of the two columns here, the two big groups of columns. The groups on the right are men and women with old school high blood pressure, 140/90. The group on the left is men and women with the new definition of high blood pressure. And the percentages are what fraction of each age group would meet this definition. So this group's the 140/90 here. This group's the 130/80. And I want to bring your attention to this middle group. And this is the people I was talking about, the kind of young adult and middle-aged age groups. If you look at what happens, particularly, and look at this, if you look at what happens in the 20 to 44 age group, in that age group with the old definition, hypertension was a relatively rare phenomenon, 10% among women, 11% among men. The prevalence in that group literally doubles, and it almost triples among men when you redefine hypertension. Same kind of increases here, slightly less proportion, although the absolute increase is pretty similar. So in men, it goes from 1/3 of men to half. In women, it goes from 27 to 44%. So you really are dramatically expanding the number of people with the disease. And one of the critiques is, if you look at the data set for who gets better when you treat their blood pressure from 135 over 85 down to 115 over 75. The data it's a fairly focused data set, which we'll talk about later. The data that treating this population of young, relatively healthy people with a blood pressure in the 130s is pretty thin. So that's the counter argument. The argument in favor is, yes, there's epidemiologic evidence that this is a risk, that this represents increased risk. And the counter argument is treating them, maybe not so much. Coming back to the guy we were just talking about, is there anything else you guys want to do with him? What's your next step with him? I'm staring at the chat box. Exercise, diet, lifestyle. Yeah. And one of you actually brought this up earlier. The other thing that you can do is go ahead and do some home monitoring. So it's not a bad idea to get more measurements. Keeping in mind, blood pressure is a phenomenon with statistical variability. So the bottom line is the more times that you measure it, the closer you get to whatever the actual number is. And even that actual number is still going to fluctuate. What we do know is that roughly half of patients have home measurements that are 10 millimeters of mercury or lower than in the office. So that is not chump change. That is the difference between, as we were just talking about, stage 1 and elevated blood pressure. We also know that the results from home blood pressure monitoring seem to correlate better with end organ damage. So both the new ACC/AHA guidelines and the US Preventive Service Task Force report in 2015 recommend correlating with home blood pressure before you just start treating people. And the same thing, the more readings you get, the more reliable it is. So one trick is if you're in an office setting with an automated blood pressure machine, which I think most of us have at this point, you can just set that thing to cycle every 2 or 3 minutes and leave it on their arm while you're talking to them about whether it's their blood pressure or other stuff. And that will give you a better sense of what the real blood pressure is, at least for that visit. I do that a lot, particularly when I'm seeing numbers that I don't like. If you don't have time for that, or if you don't want to do home blood pressures, there's a really simple formula that you can use. You just plug in a few variables and get out your calculator. And this one was actually interesting. Okay, that's a good question. So this one is actually interesting in that what they did was they took 3 clinic readings and tried to infer what their home blood pressure monitor reading was going to be, and it's actually not bad. The problem is that it uses 140 over 90 instead of 130 over 80, so it's kind of a little bit outdated. The other problem is obviously no one's going to do this at home. So if you really want to use that equation, then you can get it online. But that is like the ultimate example of a multiple regression analysis. Yeah, exactly. It's like I put the discriminant formula down. So to Lauren's question about why we don't think of BP in terms of MAPS, I think the main reason is because we have only had automated cuffs in the office setting for, probably less than a decade. They've probably had them in hospital settings for a little bit longer than that. But if you look at the data set on treating hypertension, the data set is like 20, 30, 40 years old. So the vast majority of the treatment trials were done using manually inflatable cuffs. In fact, a very specific kind of manually inflatable cuff called a random zero cuff, which is too esoteric for this talk, but was pumped up by a human being. And humans measure both systolic and diastolic. And I'm guessing that I'm not sure that it crossed their mind to compute a mean arterial pressure, which they would have had to do by hand. But it's a great question. And I don't know of any data. I know that that as you would expect for something that is based in mean arterial pressure, in general, the diastolic measurement is a more sensitive indicator of the likelihood of end organ damage than the systolic measurement. There certainly is increased risk with isolated systolic hypertension. And that may reflect the relationship between those two contributing to the MAP. It's a great question. All right, so you guys wanted to do some lifestyle stuff with this guy. Throw in there what you're going to recommend. Go forth and improve your lifestyle. Come back when it's better. Salt, DASH. Okay, John, go ahead and unmute and tell us what is DASH and why are you recommending it? Or Alex, take your pick. John, you typed first, man.
Yeah, that's fine. I think it's like a Mediterranean lifestyle, kind of food that you would eat. Basically less red meats, lean proteins, more vegetables. And I think out of all of the non-pharmacologic measures to take to try to decrease blood pressure has the highest benefit, I think, like 10 millimeters
Okay.
mercury or something.
Yep, it's actually pre-Mediterranean. Alex, did you want to add anything to that? Can't even see you. You're not even on my screen, man. All right. Um, so it is a pre-Mediterranean diet. So it's actually structured around more of a low-fat model of diet, which obviously you could consider passé. But the biggest thing there are two things that are significant about the DASH diet. One is its biggest intervention is it actually exchanges potassium for sodium. So it's high K, low sodium. And the way they do that is to load up on fruits and vegetables. So it's like both good for you and kind of does good things with the electrolytes. The other thing that's cool is because it was a publicly funded study, there is actually a DASH cookbook. It's like a 30-page color PDF that people can download. So if people are into cooking their own food and they want to switch to the DASH diet, that's great. And it is probably the best studied lifestyle intervention. Yeah, going vegan's not bad. And then Alex said, shown the most BP decrease over the other diets. Yeah. You guys are all kind of thinking what I'm thinking. His BMI was 28, so I think weight loss is totally reasonable to recommend. Nobody mentioned exercise, and exercise actually can be fairly helpful. The issue with exercise is that for most people, it's kind of you get to a certain point of aerobic exercise and it's impractical to go beyond that unless you're like a performance athlete and that's what you do with your life. So there is a limiting effect on exercise, whereas there's really not on weight loss, and exercise can help to potentiate weight loss. The other thing that I often get a question about is what about alcohol? And moderating alcohol can actually help. It's a relatively modest benefit, but one thing to keep in mind is that the data set for these numbers is also among relatively modest drinkers. So it's entirely possible that there are people who consume a lot of alcohol that would not be in this data set because they don't answer surveys, for whom reducing their alcohol intake may help a lot more. It also helps a lot with weight loss. So there's good things there on both ends. Okay, so you make all those recommendations. And he comes back and he has actually done them. Strong work. He goes to the gym twice a week. He is paying more attention to salt. He doesn't really cook for himself very much, though. So he is still eating at restaurants, such as it is these days. And his home blood pressures have been 135 to 155 over 85 to 95. Blood pressure today is 146 over 92. Okay, what do y'all want to do now? Alex wants to give the man some lisinopril. Lauren wants to treat him. Andrew wants to start intervention. I love how at least Alex chose a drug. Start intervention. Intervene. Okay. Okay, so I'm talking to an audience of internists and you don't want more information. I'm slightly shocked here. Is there anyone who wants to do any kind of testing before you just throw this guy on some pills? I'm seeing some basics: kidney function, diabetes. John wants more information. Yeah, nothing specific. Okay, so I'm here on a basic panel. Lauren wants history. We'll come back to that in a second, Lauren, when we're actually choosing a drug. Okay, anything else? Is there anything else that you have been taught that you should get in patients who present with new onset hypertension? Going once, going twice. Lipids, yeah, there we go, there we go. All right, they're coming together. So I think you guys have actually chosen most of the stuff that I would think of as reasonable. The one thing I didn't specifically see in there, although it could have gone by fast, I usually get an albumin to creatinine ratio because if that is abnormal, then that changes what I do. Those people get an ACE for sure. You probably ought to get a urinalysis, although keep in mind that with that, you're not actually really testing for microalbuminuria. You're actually looking for blood in case they have glomerulonephritis or some other intrinsic kidney disease driving their hypertension. Needless to say, we don't see that very much and it's pretty subtle. But the list of stuff on the left, most of which you already mentioned, I think that's kind of like the basic stuff that I would get. On the right are the other things that are included in the ACC-AHA guidelines. Now, you have to consider when you're thinking about the electrocardiogram that the people who wrote these guidelines read electrocardiograms for a living. I was certainly taught in medical school back when the dinosaurs walked that you're supposed to get an electrocardiogram to look for left ventricular hypertrophy as a marker of end organ damage. I can tell you I don't generally do that because if people have LVH, I treat them, and if they don't have LVH, I treat them. There is no evidence that any particular med is any better than any other in LVH, so I don't really think it adds much. The thyroid, I guess if their primary manifestation of hyperthyroidism is hypertension, then it would be a shame to miss that, but I mean, come on. And the CBC, I can't think of why you would do that unless you're using it as like, if you're using polycythemia as a proxy for sleep apnea, maybe, but whatever. What I'm saying is that neither I nor the board exams will fault you for getting any of those tests on the right, but it's certainly not something I think of as routine. Okay, so he hates needles, but you convince him, you sell him on these labs, and he goes down to the lab, and his potassium is 4.1, his total cholesterol is 190, his HDL is 60, his glucose is 89, his EGFR is excellent, his albumin to creatinine ratio is normal. Okay, now you guys get to prescribe something. Or Lauren, you can ask for your additional history. So was there any specific additional history that Lauren or anyone else wants before we start making prescribing decisions?
Maybe ask family stuff, like anyone else in your family have hypertension or any other rare genetic diseases or histories of random tumors that cause them to have high blood pressure, stuff like that.
So history of rare genetic diseases and random tumors, I think, is useful, although then you're kind of getting into like MEN stuff, and those are so rare that usually people will come in and tell you, but it's a totally legit question. Whether or not anyone else in their family has hypertension, I mean, hypertension is so common, it's like if your family doesn't have hypertension, you would be pretty weird. But it's still it's always fair to ask family history, and particularly if they do have, oh yeah, my mom had a FeO, that would definitely get your attention. John wants to know about gout. This is presumably because some drugs are better for gout and some are worse. Thiazides in particular tend to drive uric acid up, so I'm hoping that's where you're going with that. The other one is losartan actually lowers uric acid, but what's interesting is the only ARB that does that, it gives a little bonus point because it's not actually the greatest in terms of antihypertensive efficacy. All right, anything else that anyone wants to know about this gentleman before we start writing prescriptions? Going once, going twice. What was his age? I think he was in his early 50s. I'd have to like pull up the navigator. Is race still a consideration? I will come back to that in 1 second. Demographic question mark amlodipine. Andrew, I don't know what that means.
I was taught that amlodipine's very effective in the African American population.
Okay, so that's another thing about race. Okay, I got it. And then allergies. Allergies is always a great question. He's not allergic to anything. He's in his mid-50s. Let's do a quick sidebar on race, and then we can come back to prescribing something for this guy. So getting out of the chat. Oops. Let's go back here. So how many of you recognize the photograph on the left, the National Geographic cover? Remember, I can only see about 6 of you. There we go. John Goodman, biological sisters. Yeah, actually, they're not only sisters, they're actually twins. So that is Marcia and Millie Biggs. They're actually English. They were born in the UK, and if I remember correctly, their dad is actually, I think he's Jamaican. He's of Caribbean descent. And their mom is English, and he is black and she is white. And the reason why I put those two up there, hopefully it's obvious, but it is intended to illustrate the perils against trying to infer someone's genome from the way they look. These two basically share all of their DNA mixed up in different ways, and they look completely different to how most of us would sort of think of race. How many people recognize the guy on the right? Alex says Neymar. Yes, indeed. The best thing to happen to Brazilian football since Pele. And Neymar actually generated kind of his own controversy, interestingly, more in the United States than in his home country several years ago, when he was asked by an American interviewer whether or not he had ever experienced racism in professional soccer. And he said, no, not really, but it's not like I'm black or anything. And that sent the American soccerverse for a real spin. The reason why he said that is because there's actually, Brazil has its own history of slavery. There are plenty of Black people in Brazil, but only about 10 to 15% of the population actually identifies as Black. The other 30 or 40% that we might look at and say, oh, you're Black, actually identifies as mixed race. So I put Neymar in there to reflect the idea that race is really a social construct. How you define race depends entirely on your social environment. When we talk about race in the context of hypertension, largely we are talking about big studies, most of which were primarily based in America, although there were a number of European studies who asked patients to self-identify their race when they were enrolling for the study. And there were good reasons for that. This was an effort at trying to address inequities in healthcare. So they wanted specifically to ensure that they were enrolling enough people, primarily Black, but also other people of color. So there were good reasons why they asked, and they did come out with these findings that certain drugs work better in Black patients and certain drugs work worse. Where you start getting, the two places where I feel like you start getting into trouble, one is, like I was saying, when you look at someone and try and figure out whether or not they would self-identify as Black based on how they appear to you, that's obviously problematic. And the other is when you start drawing inferences that the biology of Black people is somehow different, because there just really isn't a lot to substantiate the argument that people who appear Black or self-identify as Black are somehow biologically different than the rest of us. Basically, there is a long history of scientific racism. It's pretty ugly. So I would encourage you to, if this is something that you are using in clinical practice, to ask the patient what race they identify as. And if you're doing it to try to provide better patient care, great. If this is something that you are teaching, I strongly encourage you to do more or less what I'm doing or your own version of it, where you attach the asterisk as to exactly how problematic this is and what the kind of legacy of scientific racism is in America in particular, because this is not straightforward and it's not a great tradition at all. All right, now I will set that aside. Isn't there data specifically around ACEs from African-American descent versus just Black? Well, it depends on what you mean by African-American descent. The data around ACEs was largely people who self-identified as Black or African-American, and how they self-identified depended on when the study was done, because the race question is phrased differently depending on exactly when the study was done. There is an interesting, since you're making my monologue longer, there actually is an interesting study where they went back to sub-Saharan Africa, if I remember, it was largely in Chad and Sudan, and demonstrated that in that population there actually were differences. But the thing you got to keep in mind is that there is more genetic diversity in all of Africa than there is in Europe and Asia put together. So it's still really hard to kind of draw conclusions from that. So, and like I said, I think if you're using it for practice and you're trying to do the right thing for your patients, I don't object to that. Although again, you should stay on top of the science because it's a moving target. What I object to is teaching it in a manner that suggests that race is a biologically meaningful thing. If you're going to teach about race, teach about race like marriage. It's real. It has real impacts on health. There's definitely different outcomes between people who are married and people who are not, but it's socially defined. It is not defined by anything in their genes. All right, moving on. So, John, that was a long way of sorry, I think it wasn't John, it was Andrew. You brought up amlodipine. So I got a little bit distracted there. Amlodipine actually is a good choice for this guy, not so much because of his demographics, but because he hates needles. So amlodipine is actually, and other calcium channel blockers are actually the only thing that are first line therapy that doesn't require some kind of lab monitoring, because ACEs, you're going to want to follow their potassium, but thiazides, you're going to want to follow their potassium. And that is probably why amlodipine is one of the most popular antihypertensives, and actually was so for a long time before it was cheap. It's kind of fire and forget. I think a few of you brought up hydrochlorothiazide. No one brought up chlorthalidone, which is interesting because usually there's some kind of, somewhere in the group there's an all-hat purist who's like, chlorthalidone is the one that was actually studied, which is true. Chlorthalidone also is much longer acting than hydrochlorothiazide, so it's actually probably a better antihypertensive. There is data that nocturnal blood pressure is lower when you use chlorthalidone versus thiazides. The reason why we use it rarely in practice, I think there's two reasons. One is because it's so potent, you actually get more hypokalemia, and it is more difficult to find a combination drug. So there isn't a triamterene chlorthalidone. And triamterene hydrochlorothiazide is a very convenient way to not deal with the hypokalemia of thiazide diuretics. So there's many of us, myself included, who have kind of flirted with chlorthalidone briefly, and then it's like someone comes in hypokalemic or they can't get it at the pharmacy or whatever, and you just flip back to thiazides. But it is definitely the more evidence-based of that class of drugs. So pluses to you for thinking of thiazides and chlorthalidones. As you know, ACEs and calcium channel blockers are the other two first-line drugs. And we sort of already covered the race stuff. A couple of other tips around choosing things. There is one trial called Accomplish, which demonstrated some additional benefit for amlodipine plus ACE versus thiazide plus ACE. I'd say take that with a grain of salt. It is one trial. It was large. It seemed well done. I haven't seen it replicated yet, but something to think about. I didn't see anyone wanting to give him a beta blocker, which is good. That is less effective at reducing stroke as monotherapy. Please do not think that beta blockers should not be used for hypertension in general, though. All of these big trials, like AllHat and Sprint and all these big trials, 70+% of people were on beta blockers. And the primary reason is because beta blockers, by virtue of not being included in the analysis, were one of the primary add-on drugs. So if you look at what people in AllHat, for example, were actually taking, they were taking chlorthalidone plus atenolol, or they were taking lisinopril plus atenolol. So beta blockers are fine as antihypertensives. They're just not good as the only antihypertensive. And then obviously if people aren't going to take your drug, whether it's because you chose something with BID dosing for unclear reasons, or you chose something really expensive because they saw it on TV, that's going to make it more difficult. And then one last thing I wanted to include, if you look in the ACC-AHA guidelines, they actually suggest starting 2 drugs if the blood pressure is 140/90. I dug for where that was in evidence, and there just is no evidence for that. That was purely expert opinion on the part of the guideline writing committee. It is not something that I've done a lot, and as you guys develop your own practice, I encourage you to kind of work on that and decide whether or not that's something that you want to do. You know, there's pluses and minuses. Sometimes you get fewer adverse effects with 2 drugs, sometimes you get more. Okay, so we start him on amlodipine. He comes in, he's had no adverse effects. He's paying $4 a month for it. He likes it. His blood pressures are 130 to 140 over 80 to 90. And the question is this good enough? What do y'all think? You've definitely made some progress. Everyone's keyboard is broken. Erica, no, thank you. A quick answer. Lots of no's. No, 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 no. Age again, I think let's say 55. Generally not good enough. What dose of amlodipine? 5. Okay, so no one's saying it is good enough, so we'll just go with not good enough. All right, so let's talk a little bit about targets. So old folks like me and people who are resistant to the findings of the Sprint trial will cite these as the targets of YOR, which is basically get people less than 140/90. And the reason I put these up here is specifically because in JNC 8, which came out a couple of years before the ACC-AHA guidelines, there was actually a recommendation to not go below 150/90 if people were older. That recommendation is now passé, but I wanted to include it just because you may still hear that, and it is still a population that is at increased risk for adverse effects from lowering their blood pressure too much. So that was the recommendation. The ACC-AHA guidelines, which came out post-Sprint, recommend less than 130/80 if they have known cardiovascular disease or a risk over 10%, and to consider it in everybody else. So this guy would be in the everyone else category. And they would agree that you should at least be considering lowering his blood pressure further, i.e. his 5 of amlodipine isn't good enough. They also recommending adding ACE/ARB in patients with chronic kidney disease or microalbuminuria, no surprise there. And they recommend the same threshold for diabetes. So Most of you, I'm assuming, have heard about Sprint. It made quite a splash when it was published. I'm hoping that was when you were in medical school. Maybe not. And what Sprint was, it was a large randomized control trial of patients who were really high risk, who basically had cardiovascular risk of 15% or greater or prior cardiovascular disease. And they randomized people to a target of less than 120 versus less than 140 systolic. And one thing that is very different about the Sprint protocol versus what we usually do in practice is if you showed up in the clinic with a blood pressure over 120, if you had a systolic blood pressure of 122, they increased your meds. If you think about what we typically do when we're seeing patients, usually we're like 122 is awesome, man, keep going. So this is truly targeting less than 120. This is not like 120 and change is okay. And what they saw with the more aggressive arm of therapy is that the mortality dropped from 1.4% to 1.0%. So that 0.4 decrease in mortality translates to a number needed to treat of 270. And then with cardiovascular endpoints, it was 2.19 to 1.65. So a number needed to treat of 185. So real improvements in really significant endpoints. So Sprint was a real deal, and that's why it made such a big splash. What about the downside? They saw higher rates of pretty much everything you would expect: hypotension, syncope, bradycardia from the drugs, electrolyte abnormalities also from the drugs. And they saw AKI, although if you look at what they meant by AKI, it was largely like biochemical AKI. It was, people would have a creatinine bump and then they would either rehydrate them or back off on their meds and it would get better. It was not like ATN needing dialysis kind of AKI. And as you might expect, on average, the treatment group was taking one extra pill. That was almost most folks in the treatment group were on 3 pills. Most folks in the control group were on 2. So what do I bring back from Sprint? I think the key thing to recognize is that they had a significant but not large risk reduction in a population that was very high risk to begin with. So if you are treating someone in that population, which did extend over the age of 70, then I think it's actually worth considering, can I get there? And obviously the older the patient is, the more likely you are to run into trouble with adverse effects. The thing about the guy we're talking about now is his baseline risk is pretty low. So if you look at, say he's at that hazard ratio of 0.7 for mortality, his baseline risk of mortality is really low. So his absolute risk reduction is also going to be really low, well less than 1%, probably in the neighborhood of like 0.1%. So the thing that I guess I would ask you to take home about Sprint is that when you're increasing medication, the amount of benefit people can get from the increase in medication is directly proportional to the risk of the event you're trying to prevent. So if someone has a baseline risk of 2%, let's say, over the next 10 years, they have a risk of 2% of having a major cardiovascular event. No matter how many meds you throw at them, you're not going to get their risk lower than 2%. However, the adverse effects of those medications have nothing to do with their baseline risk. It just has to do with the number of meds that you're giving them. So when you do push really hard in people who have a really low risk at baseline, you are definitely exposing them to proportionally greater risk of adverse effects versus someone who is high risk. It doesn't mean you shouldn't do it. It just means that you probably should have a somewhat lower threshold for backing off if people are having dose-limiting adverse effects or just giving you feedback that I don't really want to be on 3 pills, doctor. The other thing to remember about Sprint is they excluded patients with diabetes, and the reason why is because there was another trial which was basically identical called Accord that included patients with diabetes and had a trend towards an abnormal or trend towards a positive result that was not statistically significant. So technically it was a negative study. So nobody knows quite what to do with patients with diabetes. I would say most people think that the benefit is probably there and that Accord was underpowered, but there is also the possibility that diabetes is just such a powerful risk factor for cardiovascular disease that changing their blood pressure this relatively small amount at the bottom end of the scale doesn't make as big a difference for them. We just don't honestly know the answer to that. And then Seifu asked a question about whether there's any difference between beta blockers like carvedilol and metoprolol in blood pressure control. Carvedilol, yes. The beta blockers like carvedilol that include alpha adrenergic activity, that are alpha antagonists, actually do tend to be better antihypertensives than just straight up beta blockers. So your beta 1 selective beta blockers like metoprolol and atenolol are pretty similar, but when you talk about carvedilol, it is more potent. I don't know about outcomes for carvedilol. I haven't seen a lot of data on that, other than in heart failure, obviously. Duh. Okay, new case. 59-year-old woman with type 2 diabetes comes in as a new patient. Insulin, atorvastatin, hydrochlorothiazide, blood pressure is 133/84, heart rate's 84, A1C is 6.4, urinary albumin to creatinine ratio is 45. You have 4 seconds to type in what you want to give her. Alex beat me to it. There we go. Okay. ASARB, good. Low-hanging fruit. Prompt to talk about specific indication for specific drugs. CKD, ACE-ARB. Remember that if people have a GFR less than 30 and you need to get volume off, thiazides generally don't do much, so you probably need to add a loop diuretic for that. Heart failure, ACE, beta blocker, aldosterone antagonists, and then diuretics. Please try to maximize the mortality limiting therapies before you start pounding them with diuretics, because you want to maximize that while you still have blood pressure to work with. And then post-MI, I just put that up there to remind you that that is an independent indication for a beta blocker. Okay, 75-year-old guy comes in for follow-up with hypertension. He's on hydrochlorothiazide, lisinopril, and amlodipine, all at pretty reasonable doses. Sometimes his blood pressure is good. Today it's 180/100. His heart rate's 64. What do you want to do with this guy? I would say I could sit here all day, but there's actually another talk in about 10 or 15 minutes, so you need to help me out here, gang. What is his well-controlled BP? Great question. His well-controlled BP is like 130/84. Check for end organ damage. You can do that. The fact that he's 75 means you're probably going to find it. Ah, Erica is wanting to know about his med compliance. Okay, so's Nick. Yeah, I think that's a good place to go with him. For a couple of reasons. One is he's on 3 drugs, which is already kind of a little bit hard to take. And the other is when people have bouncing all over the place blood pressure, that's one of the first things I think of is whether or not the medications all actually reaching the patient. So thinking about resistant hypertension, and resistant hypertension is a category of hypertension that is defined as hypertension that persists despite high doses of 3 drugs, including a diuretic. And the reason why is you can see it under there is cause number 2, volume overload. If patients are volume overloaded, they're going to be hypertensive until you fix that. It does not matter how many drugs you throw at them. So if people are not on a diuretic, they don't get to have resistant hypertension. But what do I think of as causes for this? Volume overload, I mentioned. Drugs, not enough or too many. So we'll come back to not enough in a second, and then we can talk about too many. And then finally, we'll get into secondary hypertension, which we'll have to do pretty quickly, but you guys can handle it. So when thinking about why don't people take their drugs, you know, if your antihypertensives are inherently complicated or they're buried in another like 12-pill regimen, people are going to miss them. If they have cost issues and you're prescribing something expensive, which you shouldn't need to, but if you are, that's certainly something. One thing I encourage folks to do is to kind of ask people, particularly when you're proposing changes, you know, scale of 1 to 10, how likely is this to work out for you? And if you get less than an 8, that is a signal that there is a concern that you need to talk about more. Pill counts can actually be useful, but there is one catch with pill counts, and that is if you think about what people do when they bring home new medications from the pharmacy, they typically have one bottle here, which has a few pills left in it, and one bottle here, which has a bunch of pills in it. And they dump one bottle into the other bottle. And who knows which way it's going to go. But if you take the full bottle and dump it into the empty bottle, then what you have is a full bottle with a date that's 2 months old on it. And that actually makes it look like, if you look at the date on the pill bottle, that they didn't even purchase this bottle here, that they just emptied and threw away. So if you are going to do pill counts, I encourage you to not pay any attention to the dates on the bottles. And actually, if you really want to know, you need to ask the pharmacy when the last time was they had it filled. Because pretty much every rational human being is going to combine their bottles in one way or another, and it just depends on which way they do it as to what date you get on the bottle. Okay. What about, when I say drugs too much, are there any drugs that off the top of you guys' heads that you can think of that cause hypertension? Clonidine, yeah, rebound hypertension, you bet. Nsaids, there we go. Hey, the first time someone actually went for the top of my list. Yeah, absolutely. Anything else you want to mention? All right, we can go. So NSAIDs, OCPs, thanks, Jordan. So yeah, NSAIDs are at the top of my list, and the reason why the NSAIDs are at the top of my list is because they're over the counter, and the overlap between the population with hypertension and the population who takes NSAIDs for aches and pains is substantial. So I strongly encourage you when you're having someone with either new hypertension or hypertension that's not responding well to therapy to ask them about nonsteroidals, because that does make a big difference. I practice at Roosevelt, so calcineurin inhibitors is second on my list because it feels like half the patients there have someone else's organs. You mentioned OCPs, which is great. Also, glucocorticoids obviously can do it. EPO can do it, typically more kind of close to the infusion, but I put it up there really as a boards question kind of thing. Nobody mentioned sympathomimetics. I'm guessing that's because it's obvious, but if people come in high on cocaine or meth, or if they've been like chowing down on Sudafed, which is hard to do these days because it's a substrate for meth, so it's actually kind of hard to get. And then herbs, bitter orange and ephedra are actually quite hard to find now. Licorice root is still out there, and licorice root actually has an interesting, it is an aldosterone agonist. So it gives people pseudo hyperaldosteronism, but you got to do a lot of it. Like you've got to be basically chewing on licorice root. An occasional glass of tea is not going to do it for you, but it can happen. Thinking about volume overload, the things that I think about here, sleep apnea may actually be a factor. So that's something I always think about if I suspect they're volume overloaded or if I think that's contributing. And then if you're giving the wrong diuretic for the GFR, so if they have really bad kidneys and you're giving them only a thiazide, it might just, they're not taking it at all, or you haven't bothered to prescribe it. And then the last thing is excess salt intake. I actually had a patient once who, in a very remarkable feat, she was about 30 pounds overweight, and I asked her what she was doing diet-wise, and there were a number of bad things that she was doing, but one of them was eating literally a pint of ice cream before she went to bed at night. And I said, well, okay, can you sub anything else out for that ice cream so that you're not eating ice cream every single night? She said, yeah, I'll think about it. I think I can. She came back 2 months later. She had literally lost 15 pounds and her blood pressure was 15 points worse. And I said, this is not how this is supposed to work. What did you change in your diet? She said, well, I quit eating the ice cream every night. I said, that's great. She said, what are you eating instead? And she said, a jar of pickles. So she had basically subbed out her like 100 grams of fat for like, 100 grams of sodium, and both her weight and blood pressure reflected that. So, it's always worth asking. Okay, how are we doing for time? Badly. All right, let's move. Okay, 32-year-old woman who's 7 months pregnant comes in to see you to stay in touch, and her blood pressures are 148/90. You know to check for protein in your urine. It is absent in what? Okay. Jordan says, get the labetalol. Another alpha beta agent. Hydralazine, woohoo! The med school memories are still fresh. Methyl dopa, wow. Seifu, you must have read this chapter recently. Nifedipine, okay, good. So y'all are remembering the right drugs, and those are actually the 4 on my slide. So we'll just move ahead. Now I will confess, this was a little bit of a trick question because y'all thought the teaching point was going to be the drugs to use in hypertension and pregnancy, and you nailed that. Congrats. But the other thing to remember is that the threshold is actually different. So because of placental hypoperfusion, and I put that in air quotes because I like most things in OB, I have no idea if there's any data for that or if that's just what they're saying. But regardless, they have a much more generous target in women who are hypertensive during their pregnancies. They typically target 140 to 155 over 90 to 105. So if someone comes in with what would clearly be hypertension to us, but is like 150 over 95, you don't actually need to treat that person. Bad idea to let their OB know, but that's not something where you have to whip out your labetalol that day. Okay. Blasting through secondary hypertension. 33-year-old guy comes in for evaluation of blood pressure. Blood pressure is 150/94. He actually got a lab report, and the notable things on that lab was a normal creatinine, a low K, and a normal urinalysis. So you can either choose what you're looking for or how you want to find it. I'm looking for what test. What test are we going to do? Aldo-renin ratio. Thank you, Jordan. And that is for what? Oh, I'll just say it, hyperaldosteronism. I've gotten so, I just can't take it anymore. Yeah, so the renin-aldo ratio is the right test. Hyperaldosteronism is the diagnosis you're looking for. And anyone want to tell me what the clue is? Because For those of you who don't write multiple choice questions all the time, that initial blurb is called the stem, and the hypokalemia in the stem is the clue. The other reason you could choose Renaldo is it's by far the most common cause of secondary hypertension, you know, maybe as high as 10% prevalence among people with hypertension. Everything else we're talking about is going to be much more rare than that. But yes, absolutely. Young guy, hypokalemic, Renaldo, done. 75-year-old man comes in for follow-up of his second episode of flash pulmonary edema. Now it's better. Blood pressure is 154/100. Creatinine's 1.4. He's on hydrochlorothiazide and amlodipine. What test do you want to do? And Seifu, you're Dopplering his... Thank you. Whew. Okay, yes, renal artery Doppler. You have chosen to do your residency in the place where Doppler ultrasound was basically invented for this purpose. This is one of the first vascular labs in the country, so Doppler is definitely the right answer here. If you are facing a multiple choice question, anything that will tell you whether or not he has renal artery stenosis is the right answer. If you have both the option of giving him contrast and not giving him contrast, please choose no contrast. Anyone know what the clue is here? Twice. I might just ask you guys to start unmuting and shouting because this has taken so long. It's actually the flash pulmonary edema. Thanks, Seifu. You're all over this one. Yeah, there's an association, and this is real. I actually learned this as an anecdote, but there's actually literature on it. There's an association between flash pulmonary edema and renal artery stenosis. So when you see it, it's worth looking. Okay. 47-year-old woman comes in complaining of hot flashes, dizziness, and occasional headaches. Blood pressure is 180/110, pulse 100 supine, and 140/60, pulse 128 standing. Which test is most appropriate? And you know, you guys can hit the buzzer early here. You can go ahead and start typing as soon as it's obvious to you what I want you to do. Urine metanephrine, CT for pheo, urine catecholamines. All right, there we go. And what's the clue? What's the clue to pheochromocytoma? Hot flashes. Lauren, I would that were true. So the fact that she does have this kind of episodic syndrome is suspicious. But if you work up every 47-year-old woman who comes in complaining of hot flashes, dizziness, and headaches for pheo, you're going to be doing a lot of pheo workups. So the two things I would say are, A, her hypertension is sky high. So that's one thing in the setting of these episodic symptoms. The other test question clue is the fact that she's orthostatic, which is actually really unusual if you think about it in patients who are hypertensive. And the reason why folks with pheo get orthostatic is if you think about physiologically, the way that we respond to a change in position, so the way that we respond from going supine to standing, is we have a catecholamine surge. And what that does is it increases our vascular resistance and increases our heart rate so that we can respond quickly. What happens in patients with pheo is A, they're already catecholamine maxed, so they can't really have a catecholamine surge because they're already like on a dopamine drip to begin with. And because they are constantly hypertensive, their kidneys are dumping volume like crazy. So the poor kidneys are trying to compensate for this by getting rid of sodium, and they tend to actually be intravascularly volume down. So orthostatic hypotension in the setting of hypertension is a clue to pheo. It is neither sensitive nor specific. So please do not come back and tell me that you've excluded a pheochromocytoma by doing your brilliant orthostatic blood pressures. But if you see it, again, it's something worth thinking about. Okay, 44-year-old woman comes in for evaluation of high blood pressure, previously normotensive, but in the last 2 years has gained 40 pounds. Her blood pressure has gone up to 160/100, and she has to use her arms to get out of the chair. What's the test? What's the diagnosis? And what is the clue? It's very quiet out there. There's not that many causes of secondary hypertension left, y'all. There it is. Thank you, Gabrielle. Yes, this is Cushing's syndrome. Again, a lot of nonspecific findings, right? Big time weight gain, that could certainly be associated with blood pressure. But the proximal muscle weakness is a little bit more of a clue, right? So using her arms to get out of a chair suggests that she doesn't have enough quadriceps strength to stand up without bracing herself on her arms. and that is a clue to Cushing's syndrome. And yes, AM cortisol is fine. 24-hour urine cortisol would also be fine. What we honestly do most often, because it's easiest, is to actually do a dexamethasone suppression test, because that gets around the whole issue of having to collect a 24-hour urine and or having to time your labs so that you get the morning cortisol. So dex suppression is probably the most logistically straightforward way to do it. Okay, this guy falls asleep while he's at his desk. He gets a sleep study. Moving on. Couple of other things to think about with secondary hypertension. Coarctation is something to think about, particularly for step 3, because there are children on step 3. It is unusual to see coarctation in adults who have grown up in the US, but you certainly can see it in people who have emigrated to the US or who didn't get healthcare when they were children for whatever reason. Scleroderma renal crisis, this is on every internal medicine board exam, and it may or may not be on USMLE. The reason why is because it's like the only time you see a patient with AKI who you should give them an ACE. So please identify scleroderma renal crisis when you get the question and give them the ACE they deserve. If you want to, you can even do it in real life too. It's really cool. Makes you feel super smart. You already mentioned oral contraceptives, and then thyroid disease, like I was saying, pretty rare and pretty obvious when it's hyperthyroidism. Hyperpara can do it, again, rare, and then congenital adrenal hyperplasia, more often kids. But that's your blurb on secondary hypertension. I would say the general principles here are to use your history and physical. So allow the workup that you have, allow your history to direct your workup, and you do not have to send every single test at one time. So it's totally fine to rule out the most likely thing first, and then if that's negative, decide if you want to pursue more. All right. I know Renata is logging on as we speak. I have one more question for you, and that is, does anyone recognize this mountain? So, hearing nothing, that is Mount Shuxin. It's not the Maroon Bells. And Mount Shuxin is actually, if you were to turn about 45 degrees to the right, you would be staring at the summit of Mount Baker. This picture was taken from the road up to Baker's summit. This serves as a reminder that you are in a really, really beautiful part of the country at an exquisitely nice time of year to go on things like hikes and road trips. So please take advantage of those weekends while you got them and have fun. And I will see you guys around. I am going to sign off, and I guess you can stay logged on because I think Renata is going to be here in like 2 minutes. Thanks, everybody. See ya.